पेन ड्राइव?
नहीं है। फिर भी कभी भूल जाए तो पेन ड्राइव तो होना चाहिए नहीं?
वो तो अगर यहीं पे होगा तो यहीं पे मिलेगा। अगर यहाँ पे रखा होगा तो यहीं पे मिलेगा।
यहाँ पे भी प्रोजेक्ट होगा क्या? कौन सा वाला था? अच्छा, इसको कॉपी करके डाल दो इसमें।
नहीं, कैसे डायरेक्ट भी कर सकते हैं।
डायरेक्ट भी कर सकते हैं। और वो कहाँ है यूट्यूब वाला लिंक?
चलो
तो एक बार दिखा दीजिए कि मेरा चेहरा दिख रहा है या नहीं दिख रहा। स्क्रीन शेयर हो रहा है क्या? So good morning everyone. We are beginning with our class on benign and pre-malignant lesions of the uterus, and we all know that fibroids are mostly asymptomatic. 50% of the fibroids are asymptomatic and they are discovered at routine examination or during pregnancy, and the symptoms depend on the reproductive status and the site of the fibroids. Women with menorrhagia, among women with menorrhagia, 10% of the cases are because of the fibroid uterus, and the mechanism remains a subject of debate, and it's usually caused because of enlargement of the surface area of the endometrium, or it could be because of the hemorrhage of the endometrium overlying the submucous fibroid, or there can be stasis and dilatation of the venous plexus draining the endometrium, or it could be because of the disorders of the synthesis and metabolism of the prostaglandins. Patients also have complaints of pelvic pain and pressure symptoms. Fibroids usually don't give rise to any pain. Pain, however, may be present due to torsion or degeneration, or it could be because of attempted expulsion of the large submucous fibroid that presents with acute pain. Sometimes this pain is mistaken for spontaneous abortion, and expulsion may be a complication of treatment with GnRH analogs. Chronic pelvic pain can be associated with pelvic inflammatory disease. Now, the pressure symptoms, fibroids can also present with pressure symptoms. It can be because of the extrinsic pressure on the bladder. The patient will have increased frequency of urination, and sometimes there can be partial ureteral obstruction, 30 to 70% above the pelvic brim and 3 to 4 times more on the right side. When the fibroid is in the cervix or it is a lower uterine leiomyoma, then it can even lead to retention of the urine. Fibroid can lead to subfertility, and it is relatively uncommon and implicated in 3% of the couples with subfertility. The contributing factors are the presence of associated pelvic inflammatory disease. Sometimes the mechanism adversely affecting conception remains unclear, or it could be because of the mechanical occlusion at the cornual end. Distortion of the cavity can occur, which prevents the implantation, and alteration of the blood flow prevents the implantation. When fibroid is an emergency. Fibroid is an emergency in the presence of torsion when it presents as acute pain. The risk factors for torsion are when there is large subserosal fibroid with a long thin stalk. Diagnosis can be done by ultrasound Doppler, and the management is of course surgical. Sometimes the fibroid can present as prolapse, as a mass protruding through the vagina. The risk factors being pedunculated type 0 or 1 fibroid, and it can be after medical management with GnRH agonist. Diagnosis is usually clinical. On per speculum examination, you can see the mass protruding out through the vagina, and management is usually surgical. Fibroid is an emergency when it is associated with some types of degeneration like fatty degeneration, cystic, calcific degeneration, or it could be sarcomatous changes which can lead to emergency. And during pregnancy, you all must be aware of the red degeneration of the pregnancy that presents as acute pain in a pregnant woman. Presentation is pelvic pain and low grade fever, and diagnosis is made usually by an MRI, and management is just medical. So what investigations will you do? The investigations will vary according to the nature of the individual problem and the proposal for the plan of the management. Investigation must include a full blood count, and ultrasound is important to confirm and clarify the nature of the pelvic mass. Site and nature can be predicted with accuracy on ultrasound in almost 80% of the cases. There is difficulty in differentiation of pedunculated fibroid from solid ovarian mass. Serial ultrasound is helpful in monitoring fibroid size during medical for conservative treatment. MRI is not necessary for routine management of the fibroids. So, how is ultrasound important for the diagnosis of the fibroids and the management of the fibroids? First of all, it will let you know about the number of the fibroids. It will help you know the location of the fibroid within the uterus, whether it is subserosal, it is intramural, or it is submucous. Then the length of the endometrial cavity and the degree of distortion of the cavity which has occurred because of the fibroid can also be visualized on the ultrasound. Presence of submucous fibroid should not be missed, and you can go for sonosalpingography for delineation of the endometrial cavity if you suspect submucous fibroid, or a hysteroscopy. 3D ultrasound also is helpful for precise mapping of the fibroids. So these are the figures of the fibroid. You can see this is the submucosal fibroid which is completely inside the endometrial cavity. This is the endometrial thickness, and you can see these hypoechoic lesions. These are fibroid. This is the 3D image showing the fibroid. So when should you go for hysterosalpingography or hysteroscopy and endometrial aspiration? These are done to evaluate the uterine cavity, and this may be an incidental finding in a patient who is getting worked up for the infertility. It will be identified as a filling defect on HSG. It is important for the patients when myomectomy is contemplated. Hysteroscopy identifies the presence, size, and the site of the fibroid, and it helps in planning the myomectomy. Endometrial sampling should be done in cases of irregular and intermenstrual bleeding. Is there any role of MRI in patients with fibroid? When sonography remains the most cost-effective screening method? Yes, sometimes it is reserved when the sonography is equivocal. It gives you the precise anatomic location required before myomectomy in patients with infertility. And most commonly, the fibroids have decreased signal intensity on T1 and T2 weighted images. So these are the fibroids in the endometrial cavity. Hysterosalpingography, the medium of choice is saline, and procedure for identification of submucous myoma or the endometrial polyp. Texture of the submucous myoma is more heterogeneous than the polyp, and it enables the depth of interstitial extension of the fibroid. So coming to the management of the fibroids, it is both medical or surgical, and management is to achieve two main objectives. First, relief of the symptoms, and second, to reduce the size of the fibroid. It includes management in the form of progestogens, androgenic steroids, prostaglandin inhibitors, danazol, GnRH analogs, mifepristone, and selective estrogen receptor modulators, and other medical managements are in the form of uterine artery embolization. So when should you prescribe progestogens? It should be prescribed in perimenopausal women with fibroid, annular dysfunction type rather than direct consequence. There is no evidence that progestogen alters the size of the fibroid, and degenerative changes have been reported in patients who have been on progestogens for fibroid uterus. Androgenic steroids like danazol or gestagenone is useful in reducing or abolishing the menstrual blood loss. It has direct effect on the endometrium. It causes negative feedback inhibition of the pituitary gonadotrophin release. There is small reduction in the volume of the uterine fibroid by 20%. It is beneficial for short-term relief of the symptoms and is unsuitable for long-term use. Antifibrinolytics like tranexamic acid, it has recently been granted license for unlimited use. It causes reduction of the menstrual blood loss by 50% in fibroids, and it is useful for the treatment of fibroid related menorrhagia. Now coming to GnRH analogs, they significantly reduce the size of the fibroid and they act by sustained pituitary downregulation and suppression of the ovarian activity. There is shrinkage of the fibroid size by 35% after 3 months and 50% after 6 months. The effect persists only for the duration of the administration. There is cessation in the treatment followed by rapid growth. As soon as you complete the therapy and when you stop the treatment with GnRH analogs, there is rapid growth of the fibroids. There is potential risk of loss of bone mineral density. The optimum time for which GnRH analog should be given is 3 months prior to the surgery preparations, and the preparations which are given are leuprolin or gosselin 3.75 mg depot monthly subcutaneous, or busulin or nephrilin or intranasal spray can also be given. Now pre-operative GnRH therapy is given prior to myomectomy. It is given prior to myomectomy to decrease the size of the fibroid. There have been several randomized controlled trials, and they have shown that it was unable to demonstrate any difference in the amount of blood loss, time of surgery, post-operative morbidity, or hospital stay or cleaner plane. So it is justified only in anemic patients with menorrhagia and the need for surgery to buy time to build up the patient before she is fit for surgery. Now earlier we used to give mifepristone for the reduction of volume and the blood loss because of fibroid, but now we have selective progesterone receptor modulators like ulipristal, which was given in the dose of 5 mg, and recently because of deranged liver function test because of prolonged usage of ulipristal, it has been stopped and we are not giving currently ulipristal for management of fibroid. Other novel medical treatments include aromatase inhibitor fedrazole, and it produced around 71% reduction in fibroid in 8 weeks. Even levonorgestrel IUD has been tried. It decreases the menstrual blood loss, however does not alter the fibroid size, and only limitation is that it cannot be used in patients with distortion of the uterine cavity. Now uterine artery embolization is another treatment modality for the fibroids, and it has grown quickly from the infrequent choice to a major therapeutic alternative. 2 important randomized controlled trials are available, and polyvinyl and gelatin are used. These are the polyvinyl particles which enter into the blood vessel supplying the fibroid and lead to reduction of the volume of the fibroid by 42% and symptom relief in around 77 to 86% of the cases. However, we should be apprehensive while using uterine artery embolization in patients who require future fertility. Now coming to the surgical management of fibroid. Surgical management can be done either in the form of conservative surgery, where we are doing removal of the myoma, or it can be surgical therapy in the form of hysterectomy. So myomectomy can be done either by laparotomy or by laparoscopic approach, or it can be done as a hysteroscopic myomectomy when it is a submucous myoma, or laser myolysis can be done. You can see this is the laparoscopic myomectomy. This is the uterus with the fibroid. Injection vasopressin is given first, and then dissection of the fibroid is done, and enucleation is done after insertion of the myoma screw. After the myoma has been removed, the bed is resutured and reconstruction is done, followed by closing of the uterus. So the advantages of laparoscopic myomectomy are shorter hospitalization, faster post-op recovery, decreased incidence of post-operative pain, and decreased incidence of ileus and thromboembolic phenomena. However, it is associated with certain limitations, like it requires a greater degree of skill. There is difficulty in obtaining the accurate apposition of the edges of the uterine wound by laparoscopic approach. You need to be specially trained in endosuturing. Closure of the uterine wound may be time consuming, and there are certain concerns about subsequent fertility, reproductive outcome, and the long-term recurrence. This is the classification for submucous myoma. Type 0 is where there is no intramural extension. Type 1 when there is less than 50% is intramural, and type 2 when more than 50% is intramural. So SM is for the submucous fibroids, O for the other, 3 is when it just contacts the endometrium, 4 is intramural, 5 is subserosal more than 50%, 6 is subserosal less than 50%, and 7 is the subserosal component. This is the hysteroscopic view of the submucous myoma. Now, apart from myomectomy, there are certain recent advances in the management of fibroid using focused ultrasound surgery or MR guided focused ultrasound, interstitial laser photocoagulation, laparoscopic myolysis, and MRI guided percutaneous laser ablation of the uterine fibroids, which allow thermal recording of the fibroid in real time, minimizing the damage to the surrounding area. Now, coming to another benign disease of the uterus, that is adenomyosis. It is a benign uterine disorder where there is heterotopic location of the endometrial glands and stroma deep within the myometrium, and it is associated with myometrial hyperplasia. The histologic definition is invasion of the myometrium by endometrial glands or stroma more than 2.5 mm from the endomyometrial junction, accompanied by adjacent smooth muscle hyperplasia. The incidence is 20% in less than 40 years and 80% in 40 to 50 years. It is diagnosed in 22% of the infertile women less than 40 years undergoing ART. It is a disease of the junctional zone. The uterus is divided into 3 zones. The innermost zone, which is of high signal intensity, is the endometrial stripe. This is the innermost zone, the endometrial stripe, and this is the intermediate zone. The black one is the intermediate zone, the inner low signal intensity adjacent to the basal endometrium, and the outer medium is the outer myometrium. So, this junctional zone myometrium abnormality is adenomyosis is junctional zone abnormality. Now, adenomyosis can be 3 types. It can be diffuse, the uterus is globularly enlarged, or it can be focal, or it could be in the form of an adenomyoma. The theories are either it is because of invagination of the endometrium bacillus, or it can be de novo development from pluripotent stem remnants displacing the Mullerian ducts. Excuse me. Shushmita? हाँ. अच्छा अच्छा वेट करा लो क्लास में. हाँ हाँ वेट करो. ओके. Sometimes the other theory is that it is from differentiation of endometrial and stromal cells deposited after retrograde menstruation. So, the risk factors for development of adenomyosis are surgical trauma in the form of cesarean section or curettage, multiparity, spontaneous or induced abortion, endometrial hyperplasia, or prolonged tamoxifen intake in postmenopausal women. It is associated with certain pathologies like leiomyoma, most commonly pelvic endometriosis, endometrial polyp, endometrial hyperplasia with or without atypia. The clinical features: approximately 30% of the cases of adenomyosis are asymptomatic. However, it can present with abnormal uterine bleeding, dysmenorrhea, metrorrhagia, dyspareunia, chronic pelvic pain, and impaired reproductive potential. On examination, the uterus is enlarged in anteroposterior direction, generally symmetric, rarely to more than twice of its normal size, and on palpation it is firm and tender. Now, adenomyosis is associated with infertility. 22% of the infertile women less than 40 years undergoing ART have adenomyosis, and the proposed mechanism are disturbed peristalsis and sperm transport. It leads to altered endometrial receptivity and function because of abnormal secretory phase and hypervascularization. There can be impaired implantation or altered decidualization because of progesterone resistance and increased free radicals. The associated concomitant pathology like leiomyoma, endometriosis, endometrial hyperplasia, all these can also lead to infertility in patients with adenomyosis. For diagnosis, the sensitivity and specificity of different modalities like 2D ultrasound, 3D ultrasound, and MRI is as below. and 3D ultrasound is as sensitive as 91% for the diagnosis of adenomyosis. However, the definitive method for diagnosis of adenomyosis is only after histological examination. Now, these are the ultrasound features of adenomyosis. There are echogenic striations, you can see over here, or there can be heterogeneous myometrium, which is in a uterus which is globularly enlarged. Management can be either medical, surgical, or we can give a combined approach. The management will revolve around the management of the menstrual symptoms, and that can be done either through non-hormonal treatment in the form of NSAIDs or tranexamic acid, or hormonal treatment in the form of GnRH analogs, progestins, or OCP. The GnRH analogs, like in fibroid, they have anti-proliferative effect and they reduce the angiogenesis and provide relief from both the pain as well as the other symptoms. And progestins, they cause decellularization and then atrophy, and OCPs, they also lead to decellularization and atrophy. So there will be symptomatic relief to the patients on medical management. Now, GnRH analogs, they have hypoestrogenic effect, they have direct anti-proliferative effect within the myometrium. Drugs which are used are triptorelin, leuprolide, and goserelin, and the side effects are the vasomotor symptoms, reduced bone density, genital atrophy, and mood instability. It is used for limited periods of 3 to 6 months due to the side effects, and rebound effect is there after cessation of the treatment. Dynogest is also one of the progesterones. It is 19-nortestosterone derivative with high selectivity for progesterone receptors. It has anti-proliferative effect on the endometrium, and it is given in the dose of 2 mg once daily. The side effects are metorrhagia and the hot flushes, and also there are hypoestrogenic side effects like GnRH analogs, however less than them. Even levonorgestrel releasing intrauterine system has been used for the treatment of adenomyosis. They reduce the menstrual blood loss and pain, and they release levonorgestrel in the dose of 20 microgram per day for a period of 5 years, and there is no systemic side effects like other oral progesterone. It is cost effective, reversible, and long term treatment. Of course, the side effects are irregular bleeding. Sometimes there can be lower abdominal pain, breast tenderness, and headache. However, it is contraindicated when there is distorted uterine cavity because of fibroids, when there is a history of PID in the past 3 months, or there is immunosuppression of breast carcinoma. The commonest one, most cost effective, is this norethindrone acetate that inhibits the estradiol induced vascular endothelial growth factor. It is very well tolerated and effective drug, and dose ranges from 5 mg to 15 mg. Now, the surgical management for adenomyosis is done when there is dysmenorrhea and heavy menstrual bleeding that is difficult to control with medical management, when adenomyosis is associated with infertility and recurrent miscarriage, and when there is desire to preserve fertility or the uterus. Now, surgical management can be either in the form of hysterectomy when the family is complete, or it can be in the form of uterine sparing surgeries, where it can be either complete excision or there can be partial or non-excisional approaches for the removal of the adenomyoma. Newer techniques like uterine artery embolization and the magnetic resonance guided focused ultrasound surgery are not appropriate for patients seeking fertility. Now, coming to pre-malignant lesions of the uterus, and we have endometrial hyperplasia, which involves the proliferation of the endometrial glands that result in a greater than normal gland to stromal ratio, resulting in varying degree of architectural complexity and cytologic atypia. Earlier, it used to be classified as simple hyperplasia, complex hyperplasia, simple hyperplasia with atypia, and complex hyperplasia with atypia, and the risk of progression to endometrial carcinoma was in these percentages, like simple hyperplasia without atypia 1%, complex without atypia 3%, simple with atypia 8%, and complex with atypia 29%. However, recently the WHO classification 2014 is there, where the simple and the complex classification has been removed, and the hyperplasia without atypia, the risk of having coexistence invasive endometrial carcinoma is less than 1% in without atypia, and when there is atypical hyperplasia, then the risk of having coexistent invasive endometrial carcinoma is 25 to 33%. The risk factors for development of endometrial cancer, endometrial hyperplasia is almost same as the risk factors for development of the uterine cancer. The pathophysiology is excess of endogenous estrogen in patients with PCOS, perimenopausal age group, obese patients, or patients having estrogen secreting tumor of the ovary, or it can be because of exogenous use of estrogen without progesterone, or sometimes the genetic factors can also be involved. Patients usually present with abnormal uterine bleeding in the form of menorrhagia, metrorrhagia, or sometimes postmenopausal bleeding, abnormal vaginal discharge, and we should examine the lower genital tract for lesions of the vulva, vagina and the cervix, palpate the uterus and the ovaries, source of the vaginal discharge and bleeding, size of the uterus, endometrial cavity, any pelvic masses should be noted, and if the patient is obese, a pelvic examination is inadequate, and in those cases pelvic ultrasound should be done. Now, whenever the diagnosis of endometrial hyperplasia is done by sampling of the endometrial cavity using Pippel's endometrial biopsy in office, the sensitivity of which is 70 to 90%. Sometimes dilatation and curettage may be done in the operating room, and tissue sampling should be performed in women older than 40 years with abnormal bleeding and younger than 40 years in those with history of unopposed exogenous or endogenous estrogen. If a patient does not tolerate an office biopsy or has cervical stenosis, then endovaginal ultrasonography is an effective method to assess the thickness of the endometrial echo complex. It has a sensitivity of greater than 90%, 96%, and if the endometrial echo complex is less than 5 mm, persistent bleeding despite a thin stripe, then still warrants a tissue biopsy because of the risk of missing a type 2 cancer that is not associated with hyperplasia and thickening of the endometrial echo complex. In tamoxifen user, 8 mm is taken as the cutoff. So, management of patients with endometrial hyperplasia depends on the degree of bleeding, presence of cytologic atypia, patient's surgical risk, wish for future childbearing, and the treatment options are the same: ocipils, cyclic progesterone, dilatation and curettage, endometrial ablation, or hysterectomy if the family is complete. Hyperplasia without atypia, it responds well to progesterone, and more than 98% of the women with hyperplasia treated with cyclic progesterone show regression of the disease in 3 to 6 months. So, after having started progesterone for 3 to 6 months, we need to repeat the endometrial sampling to rule out whether the hyperplasia has completely gone off or not. If it has not gone, then we need to further continue the progesterone for another 3 months and then do repeat biopsy to confirm that it has completely resolved. So, with this we complete the chapter on benign and pre-malignant lesions of the uterus, and you all can go through the slides later on and then contact me if you have any confusion or any questions. Thank you. So, are we going to do discussion online? Concurrent viewers 4. Matlab there were only 4 students who have attended the class. So, but you all should also be there, na?
Yes.
So, फिर except from you all, nobody has attended the class. 9 तो 4 5 6 6 तो तुम ही लोगों 3 लोगों ने किया होगा. And what is this playbacks? ठीक. Okay. Any question? Shall I end the stream?